So I was told to do electrolytes in like 45 minutes and I'm 5 minutes late. So I think that we have 40 minutes now for electrolytes, which is pretty much impossible. So I will do the best I can, kind of focusing on 2 different cases, and hopefully it'll be interactive. But we all know how Zoom is, so it might just be me talking. All right. So just to get into it. So this is my first case. The chief complaint was a patient who came in with a brief syncopal episode of shortness of breath. He's a 59-year-old man, history of dialysis since 2013 on hemodialysis for his fistula Tuesday, Thursday, Saturday, a history of a small bowel transplant, now on Prograf and prednisone, poorly controlled hypertension, diabetes, past history of COVID, who came in with brief syncope and shortness of breath. He had his usual dialysis on Saturday and he presented on Monday. So just to point out, he's not due for dialysis on the day of his presentation. And labetalol was 200 milligrams Q12 hour. He was added about a week ago for better blood pressure control. He denies any other changes to his diet or medications. At triage, he said he couldn't breathe. His heart rate was in the 20s and his initial blood pressure recorded was 120/88. And this was his EKG. So just, what do you see on this EKG? Anyone can answer. Or what don't you see?
Okay, guys, anyone can maybe post in the chat or, I don't know, unmute yourself.
Okay, so a couple of people noted the peak T wave, which is good. So yeah, whatever severe bradycardia, peak T wave is good. So you picked up on some of the main things. So whatever T wave, whatever QRSs or T waves that he has, there's like 2 to 3 maybe on this lead. So severely bradycardic. He does have some peak T waves. There's also notably no P waves, right? The loss of the P wave. Maybe slight widening of the QRS, but really if you calculate it out, that's not too bad. And then in between is what we call the sine wave. So what do you think is going on? I mean, you said the peak T wave, which is a good buzzword. What do you think this patient's presenting with? Hyperkalemia. Okay, good. Great, guys. Okay, so our differential, so pretty much we all think this patient has severe hyperkalemia, and what should we do next? I don't know if this is all going to be through the chat, but so what is your main goals right now for this patient with okay, good. I'm thinking insulin D50, calcium gluconate, temporizing, stabilizing the membrane, albuterol, lots of calcium gluconate, yeah. So pretty much I agree with all of that. The main thing you want to do is, well, obviously get IV access. He actually had an IO placed emergently. Put him on monitoring in case he actually does go into arrest. Obtain admission labs, and then start emergency treatment, which is pretty much what you said. The first thing, probably stabilizing his cardiac membrane. So then we got some initial labs. His potassium was 7.3, lactate was 5. This is on the GEM. And his glucose was 290. His pH was okay, 7.39. And his BNP was hemolyzed, but the potassium was 8.4. A little bit hard to interpret, obviously, if it was hemolyzed. So now I just want to talk about a potassium balance before we go into the treatment. So potassium is the main intracellular cation, and its concentration is around 140 milliequivalents per liter inside the cell compared to 4 to 5 milliequivalents per liter in the extracellular space. So 98% of potassium is intracellular. And this is maintained by the sodium potassium ATPase pump, and this creates a major determinant of the resting membrane potential across the cell membrane. And when this is deranged, a lot of bad things can happen, like the cardiac arrhythmias, like we mentioned. Potassium concentration is determined by the relationship of potassium intake, distribution of potassium between the cells in the extracellular space, and urinary potassium excretion. So we have a few mechanisms of hyperkalemia. So pretty much, you can have increased potassium release from the cells or decreased potassium excretion in the urine. And from the cells, you have either cell destruction like rhabdo, tumor lysis, or hemolysis, where the cells are actually being destroyed and releasing all of that high levels of intracellular potassium, or potassium shifting, or otherwise known as redistribution. So things like hyperglycemia, metabolic acidosis, or beta blockers, non-selective beta blockers, can cause potassium to shift out of the cell into the extracellular space. And decreased potassium excretion can happen from either renal failure or hypoaldosteronism, or aldosterone deficiency or resistance. So I think most of you or whoever responded in the chat, and thank you for that, pretty much got the main treatment for management of hyperkalemia. You said two of the main things, which is stabilizing the cardiac membrane with calcium gluconate, shifting the potassium back into the cells, and that we'll see is like with the insulin or albuterol. But then there's one other thing that maybe I missed it, but it's basically removing potassium from the body. So stabilizing the cardiac membrane, shifting potassium into the cells, or removing it from the body. Stabilizing the cardiac membrane with calcium gluconate. This occurs immediately and can last from 30 to 60 minutes, and you're going to have to repeat this a few times if the potassium is still high to prevent arrhythmias. Shifting potassium into the cells, you can use insulin, you can use albuterol with a beta-2 adrenergic agonist, or if the patient's acidotic, sodium bicarbonate. The onset of action is 20 to 30 minutes and can last 2 to 4 hours, pretty roughly. And then removing potassium from the body, which is probably the more permanent way of removing potassium, is if the patient has working kidneys or decent renal function, you can use diuretics with or without saline. You can use a cation exchange resin, for example, Lokelma, or dialysis, which is actually an immediate way to remove potassium from the body. But as we all know, actually setting up patients with dialysis in the hospital is pretty time consuming. So then just going over the EKG review again. So you all noted the peak T waves, and this is a kind of classic progression of EKG changes that you see with hyperkalemia. And there's a general rule of when you see these EKG changes based on the serum potassium, but it doesn't always follow the typical pattern, and you can't always determine it just based on the serum potassium. So I wouldn't, use this as a, the golden rule of serum potassium for what changes you see on the EKG. But you should be aware of the peak T waves, which I think is the most common, as well as a prolonged PR or loss of the P wave. And then finally, a widened QRS tall T wave, which can then follow into the sine wave. And I think our patient pretty much had the sine wave with a couple of, QRSs or junctional rhythms that was pretty much keeping him alive. This is another patient's EKG with the example of these tall, skinny peak T waves. Sort of was taught to think about it as like you don't want to sit on these peak T waves. And they're usually higher than the QRS complex. So for our patient, he was still in the ED and he received calcium gluconate ×3 to stabilize the cardiac membrane. He received insulin 5 units and D50. This is to shift potassium into the cell. I think we can argue that maybe he should have received insulin 10 units here, especially because he was already hyperglycemic. Albuterol nebulized 2.5 grams ×3 doses. Again, maybe a little bit underdose here. Recommended dose is 10 to 20 milligrams. And then he got an AMPA bicarb, which is maybe arguable because his pH was actually fine, but probably helped with maybe a little bit with shifting potassium into the cells. He also received Lokelma, 10 grams, to help remove potassium from the body. Shortly after arriving, he became hypotensive and respiratory distress. He was started on BiPAP for a little bit. He was given 2 liters of LR, and levofed was started for blood pressure support, and he was admitted to the NICU. Nephrology was also obviously consulted for emergency dialysis to remove potassium from the body. And we emergently dialyzed him in the NICU. He actually needed a crashed femoral VAS cath because his fistula was not working, probably because his heart rate and blood pressure were so low. And we dialyzed him against a very low potassium bath, against a 1K bath, to help lower the potassium and remove as much potassium as possible. Before dialysis, his potassium was 6.7, and then we checked it both during, like mid-run, as well as right after dialysis. We do this to see if we need to continue our treatment. Like let's say if he still stayed in a potassium range of like 6 or so, even with dialysis, we would continue dialysis for longer to help lower the potassium. And then 3 hours post-dialysis, his potassium was 4.4. We checked it a few hours afterwards, just after redistribution of the potassium. And then levofed was weaned off the same day. And this is his EKG, actually the same day that he arrived after dialysis. And you can see here, he has normal sinus rhythm, a few APCs, I guess, but no more peak T waves and, well, sinus waves, so, P waves. So that was good. So now I just want to talk a little bit more about potassium. So potassium can be secreted at various points throughout the nephron, but it's really in the distal in the distal part of the nephron, like in the collecting duct, where you can have variable secretion. And this is really where a lot of the potassium fine tuning happens in the nephron. And this response of both low states or high states of potassium. And because of this area here in the collecting duct, in the collecting tubule, in the kidneys, you can have up to 2 to 100% excretion of potassium. So basically, the kidney can decide how much potassium, in physiologic conditions, how much potassium should be excreted in the urine to maintain potassium balance in the blood. And this is primarily through the principal cells of the cortical collecting duct, which can allow for increased urinary potassium excretion. So essentially, in these principal cells, you have two important channels. One is the ENaC channel, which allows sodium to enter from the tubular lumen, so from the urine side through into the cell, and that gets pumped out through the sodium potassium ATPase into the blood, which then creates like a negative electrochemical gradient in the lumen, which then allows potassium to go, which is high intracellular, through the ROMK or BK channels into the tubular lumen to maintain electroneutrality. And this function happens based on how much potassium is being sensed, and also due to the serum potassium, as well as increase response to the aldosterone secretion. So aldosterone will activate the mineralocorticoid receptor, which then activates ENaC and allows potassium to enter the cell and into the blood, and then causes potassium to be secreted out of the cell, into the lumen. Also, another way that this gets activated, if there's enhanced distal delivery of sodium or increased urine flow, at this point, ENaC will also be activated, sodium will be reabsorbed, and potassium will be secreted. And then obviously the opposite is true in the opposite situation, or for more like a clinical correlation, medications like spironolactone will block the response of aldosterone or competitively inhibit the aldosterone receptor. So it blocks ENaC, right, from reabsorbing the sodium and doesn't allow potassium to exit. Or amiloride actually blocks the ENaC channel, again, not allowing sodium to be reabsorbed or potassium to exit into the urine. And both of these are potassium sparing diuretics and used for blood pressure. There's lots of reasons of hyperkalemia. We sort of said increased potassium release from the cells or reduced urinary potassium excretion, kind of highlighting for our patient, in terms of urinary potassium excretion, he's a dialysis patient, so he's not making any urine, so he's not able to excrete potassium that way. He has diabetes, insulin deficiency, hyperglycemia, maybe some degree of hyperosmolality because of if he wasn't eating well, whatever. He was on beta blocker, specifically a non-selective beta blocker like labetalol, and he was also taking calcineurin, which can also raise increased potassium secretion from the cells. So he has lots of, multiple reasons for his hyperkalemia. Acidosis can trigger or cause potassium release from the cell, because basically when the serum is acidotic, to try to neutralize that, protons will go into the cell, and again, to maintain neutrality, potassium will then exit the cell, which kind of causes the hyperkalemia that we see in acidosis. And this is a nice little example to remind us that patients who do not have diabetes, so they have insulin present, have these are patients who have a glucose load, and they check the potassium over time. And patients who have received the glucose load who are non-diabetic, have insulin present that can then be secreted, which helps control the potassium as well as the glucose. Whereas diabetics are insulin deficient, so the response to the glucose load will actually also cause potassium release from the cells. And this is also looking at patients in different scenarios. These are patients without the normal patients and patients on dialysis, and their response to a potassium load. So the blue is basically just giving potassium in normal patients, and in dialysis patients, then giving potassium plus glucose. And again, I guess these are both patients who do not have diabetes, where giving the glucose will induce insulin to be secreted and can help lower the potassium. And then potassium plus a beta blocker for both normal patients and dialysis patients, the potassium levels increase a bit when added. And then again, if you give in the purple potassium plus a beta blocker plus glucose, it gets a little bit lower. And so again, labetalol is a non-selective beta blocker. Beta-2 receptor blockers impair potassium entry into the cell. And also based on the study, they share that patients with dialysis have impaired cellular uptake of potassium compared to normal patients. So it's not just the lack of urinary potassium excretion, but it's also how the cells are handling the potassium and what they can do. So this is just an algorithm on hyperkalemia. We sort of went through what to do in emergency hyperkalemia. I think the actual value of what like qualifies as emergency hyperkalemia is probably, I don't want to say controversial, but variable depending on who's treating the patient. I think it depends on their underlying medical conditions, how acute it is, how likely you think you can treat it. So I don't want to give like an actual number. I would say that probably for like most EKG changes, we don't really see much above from above 6, but I think the slide I showed you before said even peak T waves at like 5.5. So again, there's no one rule for the when to start treating emergency hyperkalemia. And then if it's non-emergent, you have more time obviously to modify the medications, optimize other medications, and do what you can. And then if you do want to use a potassium binding resin, we've been using Lokelma now in the hospital for the past, I think, 2 years. Prior to this, we were using Kayexalate, which we don't use anymore pretty much because of its negative adverse side effects, pretty much like diarrhea, which can be uncomfortable for the patient and for the nurses, as well as risk of bowel necrosis. And then I don't know if you all are aware, but there is an EPIC hyperkalemia order set that you should be using for patients with hyperkalemia, and it gives you some guidance as well. So this is not really part of this talk because our patient was a dialysis patient, but there's something called Brash Syndrome, which I think is like a newly identified constellation of syndromes. I'm not sure if you guys talk about it or have heard about this, but Brash basically stands for bradycardia, renal failure, AV blockade, shock, and hyperkalemia, which is kind of what we actually saw in our patient. And if you do case reports, I found one in a dialysis patient. But I think pretty much the idea of Brash syndrome is that there's like a continuous cycle of different things that happen that then make the other problems worse. So like, for example, if a patient's on an ACE inhibitor, and they develop a little bit of renal failure, that might worsen the hyperkalemia. The hyperkalemia can cause bradycardia. The bradycardia then causes poor renal perfusion, which can lead to further renal failure and shock. So it's kind of this cycle that goes on, and we see this occasionally. And I just been coming up in my reading about this term Brash, which I don't think is an official like disease or diagnosis, but I'm not sure. I thought it was an interesting thing and kind of does describe a lot of what we see in these severe hyperkalemic patients. Any questions on hyperkalemia or this patient specifically? I'm gonna keep going then. Okay. So case number 2, this is a 54-year-old man with intermittent asthma, GERD, presented 4 days after his COVID booster vaccine with dizziness, weakness, lethargy, as well as poor intake, increased fluid intake, increased thirst with denied polyuria, nausea, multiple loose bowel movements, no fevers, chills, cough, or shortness of breath. At home, he takes a PPI and albuterol as needed, and he's not prescribed a thiazide. His blood pressure is 128/88. I think that's actually the same blood pressure as the last patient, but anyways, the ED took these. Heart rate was 54, afebrile, and his weight was 70.5 kilograms. On exam, everything appeared normal. He appeared euvolemic, and his neuro exam was fully intact. And in the ED, he received 2 liters of NS, normal saline, and was then admitted to medicine. So this being an electrolyte case, we'll just get to the labs. So these are his admission labs. What would you say his diagnosis is? Just based on these labs. It's not a trick question.
They're saying hyponatremia. Yeah.
Good. Great. So hyponatremia. Okay. So now I don't know if we want to get into this conversation now, and it might be hard actually through chatting about what we think the urine electrolytes are. So I think I'm just going to continue. But once you approach a patient, or once you have a patient with hyponatremia, it's really important, well, one, to confirm that the patient has hyponatremia. So you want to repeat the sodium with a with a serum osmolality to confirm that it's a hypotonic hyponatremia. But then the urine electrolytes are also super important to tell you what's happening or what the kidneys are doing that's driving this hyponatremia. So this is our patient's admission labs, and this is after he received 2 liters of normal saline. So you can see that the serum sodium did not change. It was 118 before and 118 after. And this is his urine. His UA was pretty bland, low specific gravity. And these are his urine electrolytes before and after he got NS, which we're actually lucky to have had that done. So his urine sodium was 133, his urine potassium was 9.8, I guess, after saline, and his urine osm changed from 325 to 465. Just a side point, the specific gravity is kind of known as like the poor man's urine osm, but here this doesn't correlate with his urine osmolality, and the specific gravity or his urine dipstick is just, based on colors, so it's probably a little bit hard to interpret the specific gravity, or it could have been read as something different, by a different person. So we don't want to make too much of a deal about the specific gravity, especially if we have the urine osms here. And his serum osmolality was low at 246. Reference range was 280 to 296. So at this point we have, so how would you classify this patient's hyponatremia? I'm waiting for someone to chat. Okay, good. Hypotonic hyponatremia. Good. Okay, and then based on, I think his, based on his history, I think a lot of us would have expected that he might have like a hypovolemic hyponatremic or hyponatremia, or maybe like a tea and toast kind of syndrome. But the exam looked like he was euvolemic. So I think, yeah, thanks Kriti for saying euvolemic hyponatremia. So it's a euvolemic hypotonic hyponatremia. And then we'll talk more about the urine electrolytes. And yes, Nadim, SIDH is a good thing to have on the differential here. And let's see. Okay, so just get into what we did. So now just, aside on hyponatremia. So hyponatremia is the most common electrolyte abnormality in admitted patients. And this is based on a Danish cohort study that looked at 30-day and 1-year mortality for patients with hyponatremia of various ranges. And pretty much any patient with hyponatremia has a higher 30-day mortality, 2.3 relative risk compared to patients with normotremia, and then a slightly higher relative risk of 1-year mortality as well. So it is an important factor, especially as you get to more severe levels of hyponatremia for association with mortality. And it's the symptoms rather than the sodium level that's a better correlation for the severity and the prognosis. And you have both subtle and mild symptoms, which can include falls, some cognitive deficits, reduced concentration. With chronic hyponatremia, there's a higher risk of osteoporosis and bone fractures, as well as some mild symptoms like confusion, headache, nausea. And then the severe symptoms, which is what we're always most worried about, would be pretty much coma, seizures, like severely altered mental status. So in terms of thinking of, there's lots of different ways that you can look at hyponatremia. I personally like to think about it whether it's ADH mediated, ADH being antidiuretic hormone, or non-ADH mediated. For the most part, when it's ADH mediated, there's impaired capacity of renal water excretion. ADH, literally antidiuretic hormone, that you're not able to pee out all that water that you maybe should be peeing out. And this can be because of hypovolemic hyponatremia, which we see usually from diarrhea or from severe renal sodium loss. A hypervolemic picture, so like in CHF or cirrhosis or nephrotic syndrome, where you have an increase in the extracellular fluid, or euvolemic hyponatremia, like our patient, which can be SIDH, which was mentioned, hypothyroid, thiazides can do this, adrenal insufficiency as well. And then also steatosis is technically also due to impaired capacity of renal water excretion, but it's ADH independent. And for non-ADH mediated hyponatremia, mainly due to excessive water intake, like primary polydipsia or tap water enemas. So for, again, so many different ways you can approach hyponatremia. When it's complicated or unsure, I often will, like, pull up an algorithm just to make sure I'm not missing something. But first, you want to pretty much confirm it's the hypotonic hyponatremia, which we did with the serum osm. Ask if this is acute or severe hyponatremia. If it's yes to that, you want to treat it quickly with hypertonic saline. And you can give, again, various ways to treat this, but one can be 100 mLs of hypertonic saline, 3% over 20 minutes, and repeat again until we increase the sodium to 4 to 6 milliequivalents. But most of the time, the patients don't have acute or severe symptoms and usually have time to think and act on the hyponatremia. So I usually look at the urine osmolality next, and pretty much the urine osmolality tells you what the ADH status is. So if someone is hyponatremic, you expect there to be low ADH because you want the kidneys to excrete as much dilute water as possible. And that's when you see a urine osmolality less than 100. And those are situations where there's no ADH present. And that's like primary polydipsia. So you're basically drinking too much water. The kidney's doing whatever it can to excrete as much urine as possible, but it's being overwhelmed, or low solute intake, or which is like tea and toast or beer potamania. When the urine osmolality is more than 100, which is probably the more common thing that we see in the hospital, you then want to look at the urine sodium concentration. This algorithm uses more sodium less than 30 or more than 30, but I've seen others like, less than 20, more than 20. So there's no like definite, again, value for urine sodium, but think of it as low urine sodium or high urine sodium. When the urine osm is high, so there's ADH present, but the urine sodium is low, there's pretty much low effective arterial blood volume. Whatever reason or whatever is going on, the kidney is sensing low blood volume. If the patient's actually hypovolemic and it's true low effective arterial blood volume, that's usually seen in like diarrhea or past diuretic use, mostly diarrhea or vomiting. If the ECF is expanded, those are patients that are hypervolemic, and that's like heart failure, nephrotic syndrome, cirrhosis. When the urine sodium is, again, when urine osm is high and the urine sodium is high, that brings you to a different set of differential. And pretty much most of these patients, unless they have kidney disease or are on diuretics, are usually euvolemic. And that brings us to the differential of SIDH, adrenal insufficiency, thiazide use. And this is pretty much where our patient falls into. So antidiuretic hormone is produced in the hypothalamus and then stored in the posterior pituitary. It's then released into the blood whenever it's activated. And the main reason for activation is based on plasma osmolality. So plasma osmolality, normal range is 280 to 296, and you can see based on this chart that even at 280, ADH is starting to increase to maintain that osmolality. It's a really important factor to maintain the osmolality. And then later on, you also have increased thirst, which will make your body want to drink more water, again, to maintain osmolality. So when ADH is then activated, another word for ADH is vasopressin. So vasopressin or ADH will activate the V2 receptor, also in the principal cells of the collecting duct, which then essentially creates this whole cascade that puts these aquaporin 2 channels on the luminal side of the principal cells and allows water to go from the luminal side or the urine side into the cell and then back into the blood. And this stays active while vasopressin is, stimulating the V2 receptor. And once that receptor is no longer activated, the aquaporin 2 channels are then retrieved and recycled to be used when it's reactivated again. So we want to first rule out other causes of duovolemic hyponatremia because SIDH is the diagnosis of exclusion. And it can also be caused by many different things. So pretty much we rule out, ask about diuretic use. We check a serum AM cortisol for adrenal insufficiency, the TSH for hypothyroid. So this patient had a normal TSH. He actually had a low AM cortisol, and we were suspicious at first for adrenal insufficiency, but then he had an ACTH stim test.
Proud of you, though. She's had the same.
I don't think that's correct. But the ACTH stim test was normal, so AI was ruled out, and his uric acid was checked, which was low. And low uric acid, which I'll show you in a moment, also supports SIDH due to increased urine secretion of uric acid. So there's so many different causes of SIDH, and there's so many different medications that can also cause SIDH. And pretty much if it's not on this list, if you look for a case report of SIDH and a medication that you suspect, you'll probably find it because almost anything can cause it, to be honest. But SSRIs, some anticonvulsants are kind of the top there, as well as NSAIDs, opioids. And there's different, based on whatever conditions that cause or trigger the SIDH, the length of how long you have the SIDH also varies. So patients who have like post-op pain or a pneumonia that can be easily treated have a low likelihood of chronic SIDH, because once you treat the underlying condition or treat the pain or nausea, the ADH stimulus will go away and they'll recover. But other things like certain brain tumors or other tumors that secrete vasopressin, those are indefinite causes of SIDH until those tumors are treated, so much longer. So diagnosing SIDH, technically you can do a water load test where basically they'll diagnose as SIDH if the kidneys are unable to excrete 80% of the water load, or unable to dilute the urine. We don't actually do this in the hospital. We also don't measure, you could technically measure the AVP levels, but we don't do that either. It's hard to measure, they're unstable. What we can see, and what we saw in our patient, was no significant correction in the serum sodium with volume expansion with saline, but improvement after fluid restriction. Other criteria you can use is a low uric acid, a low BUN, as well as high fractional excretion of sodium and uric acid. Early predictors of failure with fluid restriction alone for SIDH, and we'll get more into this soon, is a very high urine osmolality. The urine sodium plus urine potassium is more than the plasma sodium. A low 24-hour urine volume, and a slow rise in the serum sodium of less than 2 per day after fluid restriction alone. So again, in terms of SIDH, we want to determine if it's acute, and if acute management is needed. That's basically hypertonic saline. I would say that's fairly rarely needed actually in the hospital, but should always be remembered if the patient has severe symptoms. Stop any offending agents and treat what can be treated, like pneumonia, nausea, pain, etc. Remember that normal saline will not work because the urine osms of the patient with SIDH is usually higher than the osmolarity of saline, which is 308 milliosms per liter, right? 150 milliequivalents of sodium and chloride. So all the salt in the fluid will be excreted, and the free water may be retained. So the sodium can actually drop more if you just do if you start giving normal saline. And then fluid restriction may help, but it depends on the urine electrolytes. Increasing your solid intake can help, like for example, if you give hypertonic saline, salt tabs, urea, or increase the protein intake. Increasing free water excretion, this can be done through loop diuretics or tolvaptan, and usually a combination of treatments is required. So talking often for patients with SIDH, we talk about fluid restriction. So this fluid restriction alone helps. So there's something called the first formula, which again looks at the urine electrolytes, sodium and potassium divided by the serum sodium, and you get a ratio. And depending on what that ratio is, that will help guide you whether or not there's electrolyte-free water and whether fluid restriction can help you. So when the ratio is under 1, or specifically less than 0.5, there's a lot of electrolyte-free water in the urine, and you don't need to actually do severe or strict fluid restriction, because patients might just actually start correcting on their own with with stricter fluid restriction. When the ratio is 1 or above 1, pretty much urine has no electrolyte-free water. And either you have to be severely fluid restricted, which is really hard to do, and usually you need alternative therapy as well to help promote free water excretion, like with Lasix, for example. So applying the first formula to our patient. So the urine sodium was 136, urine potassium was around 10, and the serum sodium was 118. So if you just put in the first formula, again, urine electrolytes divided by serum sodium, you get 1.2. So this shows that his urine has no electrolyte-free water, and fluid restriction alone will not help, which again, we kind of knew already because his urine osms is also very high. So he has a pretty concentrated urine. And if we want to go further and calculate the effect of 1 liter of saline in our patient, you can look at the sodium content of 1 liter of NS, which is 154 millimoles per minute. His urine electrolytes is 136 plus 10 for the sodium and the potassium. You have to assume that this is a fixed number and that they're not eating or changing anything when you do these calculations. You divide the sodium content of the saline, 154 divided by 146, and you get a number close to 1.05. So basically all the osmoles in his liter of NS will be excreted in 1.05 liters of urine. So pretty much whatever you give him, he's just gonna pee out. He's not gonna, he'll hold on to 0.05, which is pretty small. And then if you want to calculate how this will change his serum sodium, you can look at the total sodium content, which is the total body water. Remember, total body water is the patient's weight times the correction factor for their age and sex times the serum sodium. So his serum sodium is 118 times his total body water. He's a 54-year-old man, 70.5 kilos. So I multiplied that by 0.6. You get 42.3, which is 4,991 milliequivalents of sodium for his body. And then if you wanted to see what would happen after you give the liter of NS, like we said, he'll excrete 1.05 liters of urine, all those osms. So he's actually going to lose 0.05 kilos, which is pretty much nothing. So the number stays the same. So after administration of 1 liter of NS, the sodium should stay about the same, which is actually what happened to our patient, which is kind of cool to use these calculations and see what we saw clinically. So our patient was started on pretty strict fluid restriction, but we knew this wouldn't work on its own. So we also started salt tabs, which were then increased to 2 grams TID. And we recommended a sodium correction of 6 to 8 milliequivalents per day to prevent overcorrection and ODS. His sodium improved, his presenting symptoms resolved, but his urine osm actually stayed elevated, which still implies that there's ADH present. Though the salt tabs were stopped for monitoring and he was discharged with a normal sodium with follow-up. He actually had an MRI brain. It's kind of unclear why he had that ordered, but he was found to have a 1.5 centimeter pituitary adenoma, which is actually a very rare cause of SIDH. I thought maybe that it's causing like shear stress or external compression on the stalk perhaps, and that's what's triggering the ADH, but it's like there's only a couple of case reports that show this. It's not the typical finding for pituitary adenoma. So it was an interesting finding, but I'm not sure if it's definitely related to that or not. Do we have time to go on about, what time do I have?
I think we can do up until like 2:55 so that we
Okay.
give at least 5 minutes break for them before
Okay.
they have the lecture. Yep.
If you guys have any questions in the middle, please ask. I'm just going to keep talking, okay? So we all get worried about a hyponatremia, but what actually happens? And the main thing that we're concerned about is the effect on the brain and basically cerebral edema or brain swelling, which can lead to herniation and death, honestly. And so what happens is in acute hyponatremia, the serum osm of the serum osm drops from the hyponatremia, and that the intracellular, there's a higher relative osm. So water is going to go from the extracellular space into the intracellular space. This happens everywhere, including in the brain, but as we know, the brain only has limited amount of space because of the skull. So whatever cerebral edema that's there can cause the herniation and death. Over time, though, in chronic hyponatremia, the cell volume is able to be restored. And that's because the brain cells are able to exclude sodium, potassium, as well as these like organic and inorganic solutes, which then help remove also water from the brain, and the cell volume is maintained. So this is another schematic that shows what happens with the normal brain, normal osmolality. Then within minutes of being hypotonic, there's an increase in intracerebral pressure that can lead to edema. But then over hours, so then to days, the cell volume is maintained within the brain cells. And that's why the correction of hyponatremia becomes tricky, because once this happens, once there's a chronic adaptation to the hyponatremia, when you start to correct it, if you correct it too quickly, that's when you can lead to osmotic demyelination, and I'll show that in a moment. Okay, basically the same thing. So osmotic demyelination, or ODS, is due to the brain's ability or inability to recapture lost organic osmolytes, which can be outpaced by the water exiting the cells and leading to osmotic demyelination. So remember we said that the cells are going to lose potassium and other organic osmolytes to maintain the cell volume. Once the serum osm in the blood starts to go up again because you're treating the hyponatremia, more water is going to want to exit now the cells, because again, trying to maintain balance between the two sides. And this is already sort of like a smaller shrunken cell, which leads to the osmotic demyelination and cell damage. This happens mostly in patients who have chronic hyponatremia, because in acute hyponatremia, that time to adapt doesn't happen yet. With acute hyponatremia, your biggest risk is cerebral edema at that time. Severe hyponatremia under 105, hypokalemia, alcoholism, malnutrition, and liver disease are those who are the highest risk for ODS. And you can have both extrapontine and central pontine myelinosis that causes the classic findings in ODS. So just in terms of the treatment of hyponatremia, there's something called the Edelman Equation, which is another sort of formula that helps you understand that the serum sodium is equal to the total body exchangeable sodium and potassium. So both sodium and potassium are exchangeable ions. So if you give either one, that can raise the serum sodium divided by the total body water. So if we increase the serum, if we give more sodium or potassium, or the body is losing water, for example, the SIDH trigger is removed, so you no longer have ADH present, and now the kidneys are going to be losing a lot of electrolyte-free water, the total body water will go down, or if you're giving, again, sodium or potassium, the total body exchangeable ions will go up, your serum sodium will increase. And the reason why potassium is an exchangeable ion, and why we have to be careful when you're repleting potassium in patients who are hyponatremic, is because if you give potassium, it's an intracellular ion, like we said before. Potassium will enter the cell and sodium will leave, which can increase the serum sodium. And then also, if you're giving potassium, that will further, that'll increase the osmolality within the cell relative to the plasma perhaps. And then water will then enter the cell following the potassium, which then also increases the concentration of sodium. Similar is true also. Same thing happens also if you're giving potassium, hydrogen exits the cell, and then water will follow as well, all increasing the serum sodium. So what do we do if we overshoot the treatment for hyponatremia? So you're giving, you're treating the patient and you check the serum sodium again a few hours later, and it's much higher than you expected. So if this is acute water intoxication or acute hyponatremia, then you really you don't need to relower it again, because we're not worried about ODS in those situations. If the patient has a high risk for osmotic demyelination, then you're really going to want to relower the sodium somewhere close to where the goal is. And the goal for osmotic demyelination is a correction of sodium correction about less than 6 milliequivalents per day. And you can really achieve that small increase within the first few hours, and then you can stop. You don't need to continue going up, constantly, just by increasing it by 6 milliequivalents, that will help slow the cerebral edema that we're most worried about. And then if their average risk of ODS, and we say 8 to 10 milliequivalents per 24 hours or less than 18 milliequivalents over 48 hours. And if you see that the patient is, has all of a sudden a really high urine output, or you check the urine lights again and the urine osm is really low, or you see the serum sodium is now higher than what you expected, at that point you're going to be reactive or rescue the patient by preventing osmotic demyelination. You're going to want to give DDAVP to stop the urine output, right? Again, DDAVP is vasopressin or ADH. So you're going to stop the patient from urinating. You're going to concentrate the urine so they're not excreting much of anything. And you might also want to give hypotonic fluid to help relower the sodium if you want to. Alternatively, if you have a patient with severe hyponatremia that you want to correct, you can do something that's called the proactive strategy, where you're basically using a hypertonic saline with DDAVP. So you give DDAVP immediately, and that again activates ADH or gives more ADH, so the patient's not able to pee. The patient also has to be NPO so that they're not taking in anything, and then you can calculate how much 3% saline this patient needs to help raise the sodium in a controlled fashion. And it's just a case report that shows the ideal is the predicted formula, and then the actual is what happened, and they did a really good job with slowly raising the sodium. I have a couple of formulas. Do you want me to go through it, or should we stop here?
I don't know. Maybe I can ask if anyone has any questions. So that we have a couple of minutes for questions. Does anyone have anything that they want to ask?
Hope
So
you
if there's no question, I don't know if there's any, if you wanted to finish the presentation, I don't know how many other slides.
Okay, let me, so generally there are predicting formulas that can help us determine the sodium or how the sodium will change, either based on what you're infusing. So this is the infusate formula. This is like the Androgmedius formula that tells you for how much sodium or potassium you're infusing, minus the serum sodium divided by the total body water plus 1 for the liter of the infusate, how the sodium will change, or the similar formula as well for fluid loss. So for every liter of whatever you're losing, whether it's urine or diarrhea, how much the sodium will change. So you can apply these formulas. Honestly, they're not always so accurate. And I think in terms of treating hyponatremia in the hospital, it's really just following the close following of the serum sodium, as well as monitoring the urine electrolytes and urine output. Because if you start seeing a very dilute urine, those are the patients that are going to overcorrect, or ADH is now gone and the kidney is doing whatever it can to excrete as much free water as possible to return the serum to a normal osm level. So those are the patients that are at the highest risk of overcorrecting. So we can try to do one example. So this is a 35-year-old lady, 60 kilograms, who presented with SIDH. Her sodium is 110, and she has severe symptoms. Her total body water is 30 liters. So our aim is to correct her sodium by 4 milliequivalents over 6 hours to prevent cerebral edema and herniation. So 3% saline has 513 milliequivalents per liter of sodium. Based on the Androg formula that I just showed you, the change in sodium is equal to the infusate sodium, so 513, minus her serum sodium, 110, divided by total body water, which is 30, plus 1 for the liter that we're infusing. And that will change her serum sodium by 13 milliequivalents per liter. Obviously, that's too much, and we want to aim by a change of 4 milliequivalents. So to achieve the increase of 4, you would divide the 1,000 mLs of 3% saline divided by 13 milliequivalents times 4, and you get 308 mLs of 3% saline. So that's basically how many mLs she would need to increase her sodium by 4 milliequivalents. And to do this over 6 hours, you simply just divide 308 divided by 6 to get essentially 50 mLs of 3% saline per hour. A separate example, 35-year-old lady, 60 kilograms also, primary polydipsia, sodium 110, she's polyuric, she's taking 500 mLs of urine per hour. Her urine sodium and potassium is 20, so very low. For each 1 liter of urine loss, her sodium will increase by. So we would do the other formula for fluid loss: serum sodium minus urine sodium plus potassium divided by total body water minus 1 for the liter of urine loss, and you get plus 3.1 if you calculate that. So for every liter of urine she's losing without calculating for intake, her serum sodium is going to go up by 3.1. To target a sodium increase of 4, for example, divide the 4 milliequivalents by 3.1. So she'll achieve this in 1.3 liters of urine output. And this based on her urine output of 500 mLs per hour, this will happen in 2.6 hours. So in 2.6 hours, her sodium is going to already go up by 4. And obviously this is someone who's going to overcorrect. So she's someone who you can consider starting desmopressin on if you're going to prevent osmotic demyelination. And this is just another application of the first formula of looking at the urine electrolytes that I mentioned before, urine sodium plus potassium over serum sodium. So I just took this one for example. You have a 50 kilogram woman with SIDH, so her urine electrolytes are 180, her serum sodium is 120. Her ratio of urine electrolytes to serum sodium is 1.5, which is high, like we said before, which suggests that her serum sodium will decrease with fluid restriction alone, like I showed you. And then if you want to calculate it more with the ANDROG-derived formula, her serum sodium minus her urinary electrolytes divided by total body water minus 1 is minus 2.5. So for every liter of urine that she loses, her serum sodiums are gonna further go down by 2.5 milliequivalents, which is why fluid restriction alone won't work, but you have to do something to help excrete the free water or give more saline or solute. Okay, this is just my summary slide. And just remember that, of course, we're always around to help, and please consult us if you think the patient's overcorrecting or you're not sure how to best manage the hyponatremia. But yeah, I think that's pretty much it. Any questions on this?
I actually have a question from early on in the presentation. I just didn't think of it immediately. Very early on in the presentation, there was like a patient who was on levofed, I guess a little bit hemodynamically unstable and had to get emergent hemodialysis. And this might be because of my not clear understanding of hemodialysis and CVVH, but my understanding is that CVVH is for patients who are even more hemodynamically unstable and can't handle the fluid shifts of hemodialysis. Is there such a thing as like emergent CVVH? Would that work as like emergent hemodialysis, or would that be also an emergent CVVH if the patient was more hemodynamically unstable?
So CVVH is, good question. CVVH is much slower than hemodialysis. So for this patient, because we thought a lot of his hemodynamic instability was because of the hyperkalemia and the severe bradyarrhythmia, we chose to do dialysis, which in the end ultimately helped him. In other situations, sometimes you might do like for someone who's in rhabdo, you might do hemodialysis first to remove as much potassium as possible, and then continue with CVVH to continually maintain the serum sodium if there's an ongoing cell breakdown. I didn't put in his blood pressures. I mean, obviously it was low enough that he needed like levofed support. I don't think he was like incredibly, I don't think it was like that low that we couldn't just like up the levofed to help with the dialysis. Also, he's an ESRD patient, so like we weren't too worried about like protecting the kidneys if he continued to be like in shock. So we were able to just increase the levofed with that. Separately, I think maybe, you know, giving him epinephrine might have been a better choice also, because that's also a beta agonist that might help push potassium into the cells over levofed. But either way, he, you know, by the end of the day, he was hemodynamically stable, normal sinus rhythm, and off pressors. And he didn't, his hyperkalemia didn't rebound either.
Thank you.
You're welcome. Any other questions?